You have to be awake because it will be more of practical session than to be more of theoretical part. So be more attentive to this discussion or the way of demonstration that makes your learning capacity of how to do a motor examination, sensory examination, and cerebral examination. Probably it will be covering up within the motor part, the cerebral part also. Okay. So what are you going to do now? So first and foremost going to be your the attitude of the limb. Inspection is very important in a neurological case, both for attitude of the limb, even during the walk, how the patient is being able to walk, the style of walk, or the gait has to be assessed. Gait is nothing but style of walk that has to be assessed. So how are you going to do? What are the things expected from the exam point of view? What do you think the common attitude of the limb?
In hemiplegic patient, in upper limb, we can see adductor, shoulder adductor, internally rotated, elbows flexed, and wrist flexed, and thumb inside the palm. That shows health. Fingers are flexed.
Opposite group is there. They're against you. You are correct, they are correct. What is Pandaribai position? Do you know Pandaribai position? What is Pandaribai? This Rajini film was there. What's the name of the film? Not Pandaribai. Position of the Pandaribai position. Classical position, what she used to maintain in the film Pandari. She used to keep it. It's a correct position. So it's definitely should tell when the attitude is supposed to look for the shoulder joint, elbow joint, wrist, not only that, IP joints. See the IP joints. Okay? It's very important. Any patient motor system examination starts with and make it as a habit to present in relation to joints. Whether it's the attitude of the limb or power examination, tone examination, each and every segment of the part of your limb has to be assessed and try to present. Because you have the corticospinal tract, non-corticospinal tract. Examination point of view, it's very common to have a corticospinal tract involvement. We're expecting a difference in the distribution of the group of muscles. It is not the one limb. Today morning we are discussing about disparity of power involvement between the lower limb and the upper limb. Now I am trying to tell you is the difference in the involvement of each group of muscle involvement. Next level. Okay, so try to understand that also, and as already we discussed in the morning also, the involvement is going to be majorly in corticospinal tract. The fine skeletal movements are affected in distal part. The proximal involvement is not commonly involved. Whereas no involvement or the muscle involvement, primarily muscle through proximal involvement. So this patient, a person with a hemiplegia, classical corticospinal pyramidal tract involvement, upper motor neuron type of this is what I am going to come up with the examination. The attitude from the joint point of view should tell the position. Okay? Yes. We should know the explanation for why it's happening. Examiner asking you why it's happening. What is the answer? So it's definitely anti-gravity muscles are grossly affected with the tone or power is concerned. Definitely. So the anti-gravity muscles are keeping your limb in the posture what you are trying to explain for the attitude of the limb is concerned. Okay? Yes. Second one is what else you want to look for? Okay, then muscle wasting. Because in a short case, we may not be knowing the duration of the illness. To make it easy for you to tell the possible duration of the illness, probably months together, it's easy for you to look at the limb, the bulk of the muscles. That's very important. So look for the bulk of the muscles also. It is not only attitude but also bulk of the muscles. Then
any fasciculations?
So additional movements of the musculature to be looked for, specifically fasciculations to be looked for, especially at the
muscles around the waist.
upper limb. Commonly look for the deltoid region or the forearm muscles. Be able to see for the fasciculations. Try to look for that. Suppose if it's not there, your suspicion of element disease is more and more. What you're supposed to do? So try to reinforce to find out the evidence of stimulated fasciculations is there. It's open or the straightforward case of fasciculations without any stimulation also possible. You're suspecting element disease, always try to go for stimulation and try to find out, but flickering on that part can make that. Or hyperventilation also can make your, similar to your calcium deficiency where you can get similar to that, you can get this type of changes also. Okay. Anything else you want to look for?
Any involuntary movements?
Okay, good. So what are the involuntary movements you can expect?
Microlesions.
Okay. Tremors.
Korea.
So you can tell all the commonly, but examination is concerned, the stroke patient usually expecting tremors can be there. Then myoclonic jerks usually sign of cortical irritation. The sign of cortical irritation or cortical dysfunction. Okay, then anything else you can get? Chorea, heavy bowel disease, all those things can be mentioned, but it's not very common for your actual level of learning for undergraduate level. Okay, you should commonly know about it. Anything else you want to look for?
So, look for basic and hypothyroid.
Bulk is the one. Bulk is supposed to be anything else.
Any deformities?
I will sit about the deformities and the joint level. Anything else? Trophic changes. So more fine it is supposed to inspection wise. Try to look for trophic changes. When there's a hemiplegia, there might be some sort of changes to the peripheries also. Most of the time, trophic change is sign of autonomic nervous system or gross involvement of associated peripheral nervous system also. So these two things will make your presence of your the trophic changes. So basically, attitude of the limb. First to start with limb, upper limb, lower limb. The involvement of muscle bulk to be looked for is inspection wise. Then trophic changes, involuntary movements which include the fasciculations also to look for. Suppose nothing is visualized, try to look for stimulation, try to find out is the evidence of involuntary movement, especially in the form of fasciculations. Trophic changes also. Anything else you want to look for in external examination is concerned other than the motor system in that gross neurological classification? Simple gentle points. It's not related to motor system. Always you look at the catheter. Okay, always you look for the catheter. Often missed and not mentioned by the student. Most of the time they would have had a look at that catheter, urinary catheter, but they will not mention about it. Both in the history and examination, including the diagnosis. It's a gross mistake. It is not acceptable. So try to look for that. There may be evidence of bladder involvement, sphincter involvement, spinal cord involvement, can be brain involvement, the part of frontal area, can be anything, anywhere else can be involved. Can be a simple reason for patient was unconscious, where they thought patient needs to be supported for the urinary catheterization. So there are so many reasons for catheterization which we don't know unless you have the history. I'm talking about inspection wise in a patient, you're supposed to look for this. And never forget to examine for the back. Never forget to examine for 24 hours old patient. More than bed sore. That's what back has said. One more area. No, why ankle? Above the ankle. DVT. Okay, so patient is immobilized for more than 24 hours. It's a part of your examination for the people, those who are doing daily rounds and undergraduate exam is concerned. Postgraduate daily rounds, it's a must to examine for any stroke patient. Immobilized in the bed, It's a must part of your examination to look for calf muscle tenderness, to look for evidence of DVT. Suppose if we have a problem of, for example, cardiac source of embolization that leads to your stroke, what are you supposed to look for on a daily basis? Always examine for all the pulses. So all these things are simple ways to look at. Okay. So we move on to the first part of your examination skills demonstration. You're going to show me how you're going to demonstrate the motor examination. Already discussed about inspection part. In addition to the additional points which we discussed, like pulse examination, DVT examination, bed. So we'll move to the per se the primary examination of the motor system. What are things we're going to do? So before that, the prerequisite is always expose the part of the examination. It's applicable to your sensory examination or motor examination, which includes different components of the motor examination. So you should know the prerequisites, because most of the time if you see objective or structured clinical examination, OSCE type of examination, you'll be watched whether you're following the steps of examination which requires or which is going to be assessing your prerequisites for examination. Introduction about the patient or introducing yourself to the patient and thanking the patient, all those things are part of your assessment tool for the examiner without even talking to you. So it's very important to tell the points in order so that you don't forget to, it should come as a reflex now. Okay? So you're going to expose the part examination. Assuming this patient is having right side hemiplegia, start showing me how to examine the motor part. You can keep this one. Yeah, Mike. I tell you this patient is having right side hemiplegia. I wanted to examine the motor part of this patient. Already I've done the inspection. We're going to do palpation. Okay, just keep in mind. Yeah, no, the order should not be changed. Always bulk. Always bulk. Attitude followed by bulk. Then followed by power. Followed by tone. Go again.
Examine the bulk of the arm. I'm supposed to take measure it from a point 10 centimeter above the vertical process.
Or the bulk, what do you expect? Always expecting lesser number on the affected side than the unaffected side. You are expecting the lesser number on the affected side. It can be equal, can be more also, it is acute even. You don't expect any change in the bulk, it's going to be acute even. So chronic event, definitely you are expecting bulk to be small. Okay, so that's equal because the dominant side is involved. Right side is a right-handed person. You can expect the bulkier muscle than the left side. When the weakness is happening, wasting is happening, it will be slightly lower than the previous one. But it is going to be equal to the other side. Understand? Okay, then next one.
Then to assess the bulk of the forearm, I'm supposed to take a point 10 centimeter from the medial end.
Okay, then hand muscles. Any measurement you can do? There is no measurement.
To assess the bulk of the lower limb.
Leave it. Over the clothes. Going to over the clothes. You should know that it should not be done over the clothes. You do it for the continuous day.
So to assess the bulk of the thighs, I'm supposed to take a point 18 centimeter above the patella.
Suprapatellar or infrapatellar? Okay, then down.
Down 10 centimeter below the tibial.
Okay. You should know the measurement Always expose the part. Only for practical reasons we are not exposing the clothes. Okay? Yes. Then next bulk. Show me the power and tone. Power.
Power is nothing but the force of contraction exerted by the voluntary action.
Show me
For upper limb power, we look for shoulder.
right side hemiplegia. Right, go.
Upper limb, we look for
Action. No theory. You can give a commentary while doing the action. Yes. Just observe her examination. You might be following her way of examination, or you might find a way not to follow her way of examination also. Keenly watch. Yes. I'm not telling that you are wrong or right. Okay. Yeah, go ahead. Okay, leave it. Anybody else? You're all very partition. Segmented yourself for examination techniques. Steps. Because you will not be given the same type of examination steps for your exam. You are supposed to do everything. This should be that. Hand muscle. Hand muscle, hand muscle. I am not explaining for undergraduate level detailed small muscles examination of the hand. But just tell me how to do a gross examination. The hand grip is the easiest way to look for hand muscles. Number 2, in between the, yeah, can do that and look for any evidence of wasting is there, hypogenetina. But before moving on to the per se examination technique of the motor examination, especially for power, what is the gross mistake done by them? All the 3 steps which I asked them, what is the gross mistake done by them? So I told them, repeatedly I was telling them, right side hemiplegia patient, right side hemiplegia patient. They started examining the right side. Always start the examining the normal side followed by abnormal side. It's a basic dictum. It's a dictum. It's a rule of percussion, not a dictum. It's a must always explain the patient. She was trying to explain to the patient right side. Tata Pinadi Munadi. It's not going to work out. He is already weak or already paralyzed. You cannot expect him to cooperate. So in that case, easy for you to explain to the patient the normal side than to the right side. That is the abnormal side. Always explain your expected examination technique, what is result expected out of that. All those things will be explained to the patient only on the normal side. So first and foremost, motor examination, especially power, movement of the joints, starts with any local tenderness there or not, any stiffness is there or not, before moving on. Second major mistake done by her, not by her alone, by the team. What is the second major mistake? First one is examine the normal side followed by the abnormal side. Irrespective of asking examination, irrespective of the examination is over, the examiner will ask you to demonstrate. You are supposed to start with the left side, means normal side followed by abnormal side. The examiner specifically points you to examine only the abnormal side, go for abnormal side. Otherwise, always, because maybe one of the observations done by the examiner. Okay. Second major mistake. Pain she was asking for tenderness and local stiffness, and she examined. First point she did. One more major mistake. That was not completely done. She was trying to explain halfway, whichever way she knows, but it was not completely reaching the patient's brain. Okay, that's different story, but it has to be clear. Major mistake is What is the mistake?
Resistance started to give resistance service.
Why? Is it correct or wrong? So you should know the grading of the power. You have the 0, 1, 2, 3, 4, whatever the grading is there. But it's going to be without offering the resistance. Try to understand patient's power is okay or not. Muscle power is there or not. Without even understanding the patient's muscle power, whether it's with resistance or without resistance, offering the resistance is not the way to check. So when you're going to ask the patient to do the movement or muscle contraction or agonist action, all these terms are very important to know why we are following these steps of examining the motor power and the tone. Okay, so agonist action or the muscle power or muscle contraction, look for, always ask the patient to do against gravity. Against gravity. He is able to perform against gravity. What is the power? So try to offer resistance. Try to offer maximum resistance to find out the normal power or not, or 4 by 5 or not. So it's very important to start with always whichever the joint group of muscle, whichever the muscle your agonist group you are trying to check for, you are supposed to do only against the gravity, followed by the person is not able to perform the against the gravity, then go for lower one. Then gravity is eliminated, then go for other one. Okay, so always start with without offering the resistance, go for. And another important thing is, in a person of this nature, it's better to do it in the supine. I only made the patient sit up, but only for practical purpose. You do it in the lying posture or sitting posture also. Okay, so motor power is always an active examination. Motor power is always an active exam. Tone examination always a passive examination. So what does it mean to you? Can you just come and show me the difference between examination of tone and the power? The upper limb. Go into the abnormal center. Always explain the patient. Okay? Understood. Okay, go ahead. I am saying right side hemiplegia patient. I want you to tell me how you are going to demonstrate the power and the tone.
Extension for the biceps. So we are giving
What is tone? Any one of you? Yes. Yes.
tone is defined as the partial resistance offered by muscles in stretching partial state of contraction by resistance offered by the muscle against the passive.
It's a partial resistance offered by a group of muscle at rest within physiological limits. Go and take your canon, the physiology, guidance physiology is given the definition is, it's a partial state of resistance offered by a group of muscles at rest within physiological limits. What is physiological limits? We will not go into the detail of that. Okay, but this is the definition of your, that means you are trying to assess. I was telling just minutes back, you should remember the agonist and antagonist. Another term which you are talking about is active examination, passive examination. So power examination is always called as active examination. You try to make the patient actively involve the group of muscles to assess the power. Whereas tone examination is a passive examination. You try to assess the tone of a group of muscles when the muscle is at rest. She was telling she was trying to understand the tone of biceps muscle when she is trying to do extension. Extension means your examiner is doing passively extension movement, that means actively making the triceps muscles to contract done by the examiner. But by the time the biceps is at rest, you try to understand how much is resistance offered by this group of muscle at the time of extension movement to know the biceps group of toe. So usually we see examination is concerned, undergraduates, postgraduates also will keep on moving the limb and says hypertrophy. So without knowing why do we do that movement. Okay. So by doing the movement, try to do flexion movement, extension movement. While doing the tone or the power, always try to feel the muscle. The next mistake done by you people is not feeling the muscle. Always try to feel the muscle and try to understand the nature of the muscle, power as well as tone. So I try to do that, show me that biceps tone, doing the movement, flexion, yeah, extension. Now she's trying to learn, trying to understand the biceps tendon, biceps muscle tone. Doing the flexion movement, she's understanding, yeah, keep that, trying to understand the triceps tone. So meaning that it's a passive examination. The antagonist group of muscles assessed for tone. The active examination, the agonist group of muscles assessed for power. Okay? So agonist means whichever the muscle is subjected for contraction, you are assessing for the power. Whichever the muscles at rest, you are trying to check for the tone. So basic, the clinical medicine principle tells you why you do this movement. Another point is you are trying to offer resistance in the muscle power examination. Right? You are trying to do that. You are trying to offer resistance here, you are trying to offer resistance. How do we offer the resistance? Where do you offer the resistance? Correct. That's understood. You are making the agonist muscle flexion movement. You are trying to offer the movement of the flexion of the biceps. You are offering the resistance. My point is, which part of the limb you are going to offer the resistance? Where?
For abduction of the
No. Flexion, tell me, flexion of the elbow. Help me. I wanted to show where to offer the resistance for demonstrating 4x5 or 5x5 power of the biceps right side. Anybody? So whenever there is a joint, okay, whenever it's joint, here this joint is here, elbow joint is there, the weakest point of the joint is going to be the ends of the joints. I'm talking about in relation to power, in relation to basic physics. It's not a physiology. It's basically physics related information tells you that's the most weakest point. Even for a Bhagwan, if you are going to offer the resistance here, you will not be able to come against or go against your resistance. Okay? So weakest point. So always try to offer that resistance. Always you want to offer, just try to offer resistance. So very important, see to that the muscle is offered the maximum capacity or maximum friendly environment for the muscle to express its action. That's very important. We're going to offer resistance here, weakest point. I will not be able to go against resistance. If we say 3/5, 4 minus by 5, all those numbers will come. Unnecessarily underestimating the muscle power. So always try to go for the resistance here. Can you ulla madakku paappu? Ulla madakku? Yes. Ipo madakku? You cannot do that. Because I am offering a resistance in the distal portion. Similar to this point on. Both the areas he was offering or he was pushing more power to overcome a resistance. I offer the same resistance. He is trying to overcome my resistance by offering extra power. Whole body is shaking. Because the resistance what I am offering is the weakest part. Try to avoid these areas. Always try to offer the middle part of the arms also. Whatever the muscle group you are going to check for. The basic principle is going to be try to offer the resistance at the middle point of the joints, not at the ends of the joints. Okay, very important. So agonist group, active muscle, look for the inspection as well as the palpation of the muscle is very, very important. Offer to start with, whether going against the gravity is possible or not, then try to offer resistance to be offered. Never try to jump into resistance not to be offered at all. Okay? Tone, always go for the antagonist group of muscle tone, otherwise passive examination. you are supposed to look for. Okay? And hand examination, if you are able to do at least hand gripping, both sides, try to understand the power of the hand muscles. Undergraduate, if you are able to do that, it's well and good, accepted. It's always measured the percentage. Okay? Not in numbers, we have different numbers. Okay? This is regarding the motor examination, the power and the tone. Okay? Same rule applicable for your lower limb. How does the lower limb power? Sorry, tone? Always two ways to do that. Roll the lower limb in the bed and try to understand the resistance offered by the group of muscles and try to lift up the knee joint and understand, lift up and leave it back. How much is able to hold on to the air or not is going to tell you about the tone of the group of muscles. Okay? Yes. Moving to the next part. Next part of examination. Yeah, go ahead. She's expert. Flex, come on. No, just show me the first deep printed. Since we are talking about power and the tone, I want to show me the deep printed reflex. You are there. Oh, deep printed reflex. Come. Go ahead, anyone of you. Those who are not shown, you should. She has not shown. Yes, show me the deep printed reflexes. I want to demonstrate once again the same principle to be applied, normal side followed by abnormal side. The parts to be exposed. Because repeat I'm telling you should not forget that. It should be at the spinal cord level, spinal reflex. Even decorticated specimens should be able to do this. Exam, if you see carefully, everybody will be tensed up. More tensed up is the examiners. Who causes the major examination tension for the examiners. But students, might you pause and see how it goes. You will tackle the exam as the tendency of the students. But very important, even at the time of tensed up mood, you should be able to do the examination techniques. It's like your Pavlov's pouch. What is Pavlov's pouch? Pavlov's pouch. Physiology. First MBBS, first year physiology part 1. Here the dog's pouch or stomach is being trained for ringing the bell. It starts eliminating hydrochloric acid. It's called as Pavlov's pouch. It's a local reflex mechanism. Your way of examination at the time of examination is concerned. Even if you are going to be tensed up, you should be able to do the reflex. That's why it's called a spinal reflex. No brain is involved. No communication is going to the brain. Spinal reflex comes on its own. The steps to be followed. Each and every step is just reminding you about expose the part, normal side, followed by abnormal side. At least 10 times we are going to say that it registers your brain and goes to the spinal cord. Yes. Go ahead. She is going to demonstrate biceps. Biceps. Where is it? Which one is biceps tendon? Yes, that is biceps. Yes. Is it there? It's not a vibration, doctor. I don't want vibration. I want the elbow to move. Why it's not moving freely? She is keeping her forearm. The patient is keeping his arm separately but both parallelly, and it is not rested by the exam. The problem here is she is making the examiner patient's biceps to be torn position. You will not be able to exit the reflex. The muscle to be at the optimum position for demonstrating deep tendon reflex, otherwise called as stretch reflex. The stretch has to be done in a proper way. Otherwise, what is the law? The stretch is more and more gives way. Stalling's law. Stalling's law. It is not truly applicable. It is similar to Stalling's law, where it's applicable for your heart muscles. Okay? Similar to that, you have this. The stretching of the tendon has to be optimum position to get the stimulation of the receptors, to get the maximum output of reflex. Otherwise, you don't get whatever the reinforcement maneuvers you're going to practice is not going to get you the reflex. Okay? That's what you're supposed to support the forearm. Patient's arm to be supported by the examiner's arms. It is not enough. You cannot keep it straight because it's too tight. Right? You cannot keep it loose out. It is too loose. You will not get the response because the tendons are not stimulated. Now, partially. Okay? Rest on your forearm. Slightly flex. Yeah. Loose out. No supporting. Yeah.
அந்த சைடு வைக்க முடியாதுல கேமரா தெரியல அது மட்டும் ஃபோக்கஸ் கையை மட்டும்
Now I am doing my finger. It is not placing the thumb. I am stretching it now. I am going to do the movement above downwards. I am not doing any other directions because once you give a stretch. So how much stretch I am going to give the tendon, I will expect the response to be brisk. Okay. But still, it's not too tight. Go loose. I want that to be. Now I will stretch it out. You can see the other response also. This is finger flexions also happen. But that is the additional observation. But first is contraction of the muscle, movement of the elbow, followed by finger. This is biceps. Triceps similar to the loser. You also keep it over the chest wall, okay? Or you keep it like this. No need for completely rest on the chest wall. It's only the stretch of the neck is very important. Suppose do that. See the contraction of this. You see the contraction here. We now look at this contraction of the biceps. See the triceps. It's only the side just to be selected properly. Side just to be selected properly. And the stretch of the neck is very important. It's very important to give the proper strike over the tendon to get the proper response. Okay? This is regarding the triceps and biceps. Supinator reflex. You don't have to come, you come. Yes. Right is just this part. Yes. Yes.
Tap directly.
So all these prerequisites are very important. Do some. There's something with you now. What is it? Some days you may not be getting just the answer. See that? The leg was slightly stretched. I'm stretching it. See the contraction. So it is giving the very important side of selection of the tendon is very important. We have stretched. I'm stretching by this movement slight and I'm doing the movement from here. See the difference? There is no much of contraction. Very, very minimal contraction. See the contraction. See the contraction. Much better. It's very important. The position of the limb is very, very important to have the proper response. It's basically the physiological principles applied areas of clinical examination. Whatever I am trying to demonstrate is physiological principles applied. So unless you maintain the proper environment for the muscle to express its function, it's very difficult to demonstrate. You cannot find fault with the patient. It is your inefficiency, inadequate knowledge, inadequate skill of exposing your knowledge is not to be blamed to the patient. It's your ineffectiveness. Okay, it has to be properly learned by you. Okay, so lower limb, knee jerk and ankle jerk. So what are the ways you can do? You can do it in the sitting posture, you sit in the lying posture, even the prone position. Okay, but how are you going to do that sitting posture? Everybody has to like to show. Yes, come long time. Rotation on the tail. Yes. How are you going to do that? You do it the cross leg. You take the patient cross leg. The normal position. Now it's ungood. Now she's, you see, when he's trying to put the cross leg, he's trying to keep it close. What will happen? Two stitch. You don't want it to happen. Ask him to feel freely hang it down. Loose out. Now it's 90 stitch. Now I'm going to focus here. See there? I'm not exposing this part, but this part has to be exposed. You can do with your finger, you can do with your hammer also. Always try to do not this way. This is the stretching of the tendon. Okay, always try to stretch the tendon. That's why it's called a stretch reflex. So the direction of the strike also has to be above the ideal one to do. Okay, this ankle reflex. In this position, how are you going to demonstrate? Come. Do it. I want you to demonstrate ankle reflex. Is it possible? Yes, it is possible. It is possible. Show me that how you going to do that. Yes, the examiner has to sit down or no, kneel down, something like that. Then, no, already has dorsiflex. Before she started doing the dorsiflexion, he himself is dorsiflex. What will happen? Just tight. You will not be able to demonstrate. So keep on, talk to the patient, convince the patient to not to do any movement on the ankle joint. Let her do the slight stretching and try to do the movement above downwards. Be able to demonstrate. But by doing that, once again, the exposing the part, number one, feel the muscles also to be done. Okay? Yeah. Achilles tendon. This is the Achilles tendon. So patients quoted in the form of doing all this cleaning the or arranging the or adjusting the clothes. That means you will be having a voluntary control on the muscles. Always you have a voluntary control on the muscles. It's very actively in the process of examination. You should not allow the patient to be actively involved in the action of the process of examination. That means he's having concentration on that part, it will disturb your function or the outcome of your results. You will not be able to reach. Or that's the reason I always try to divert the patient. Keep on talking to the patient, divert the patient what is going on. So definitely nail down because sometimes the examiners very specifically ask you to demonstrate if the person what the patient is basically maintain the neutral position. They don't want you to be on the bedside or anything. You should know how to demonstrate a reflex in the position already. Patient is seated comfortable. Okay, so you can do that ankle reflex in this patient. How to demonstrate plantar response in this patient. We'll finish on the lower part. Ideal one is lying posture, but in this position we are going to demonstrate. Or what are the requisites for demonstrating plantar response? Yes. Is it required for plantar response? Knee flexed, externally rotated is really required. It's only required for ankle reflex, not for plantar response. That's not for plantar response. The requisites are exposing the part, but ideally speaking, up to the level of upper part of your thigh portion, because you are trying to look for the contraction of the tensor fascial area. Okay, but the knee joint other things not very important. The position can be straight also. But what is very important for demonstrating? How are you going to do that? Yes. Holding the only lateral medial malleolus without touching the extensor hallucis longus. Why? This is the tendon of This is your extensor hallucis longus. This is extensor hallucis longus coming up to this level, or from here to this level. So the EHL should not be disturbed. Once again, the same principle of allowing the muscle to express. Okay? You are going to hold like this. You are not allowing the EHL to express. Hold it like this, then followed by. That is first point. Yeah, always check for the grade 2 movement. Stiffness or tenderness is there or not, or inflammation is happening or not. Followed by holding the medial malleolus and lateral malleolus. Then this point up to what level?
From the knee to the small toe,
Knee.
and
Heel.
small toe, and then you have to go inwards till the
Second toe. Don't come to the level of ball of the grade toe. Don't cross the level of ball of the grade toe, because we have a local reflux arc is there, which will start stimulating and produce some sort of abnormal response. So always the point to be checked for the grade toe movement or stiffness. Hold the medial malleolus, lateral malleolus. Use the object up to the level of second toe. Don't cross first toe. Another important point to say withdrawal response or not, the initial 1/3 of the distance after your stimulation, after strength, if you are getting any response, it is considered as withdrawal response. That is, from this point to this point, if you are getting any response, it is abnormal response in the form of withdrawal. Trying to reduce your intensity of the stimulation. So initial 1/3, any movement, forward movement or backward movement of the grade toe, doesn't matter, it is abnormal. It is considered as a withdrawal response. Try to avoid that. Okay? Yes, this is the basic requirement. Other methods to be followed, but any reflex, if you are not getting first time, second time, immediately go for reinforcement. What are the methods you can use for reinforcement?
Ask the patient to turn opposite side.
Cleanse.
You can talk and listen to that.
Yes, only conversation is enough. Or you can do the hand locking, interlocking of the fingers, or clenching of the teeth. So many ways to distract the patient, basically diverting. So you try to understand whether you are able to elicit the reflux or not. Okay? Yes, this is regarding that. The other methods to demonstrate, which is the most useful sensitive test for your plantar response. Chaddock sign is the Chaddock method is the best method for demonstrating the plantar response other than the conventional method. Not open gaze. It is Chaddock's method. That is
Below the lateral part of this, we should strike
the lateral part of the from below upward. That is lateral malleolus, the heel to the forward. Reverse Chaddock is from the distal to proximal. From proximal to distal is Chaddock. Reverse Chaddock is from the distal to proximal. Then you have the squeezing of the calf muscle, squeezing of your Achilles tendon, or the movement of or pressure is applied over the shin region. These are the few ways to look for the plantar response. Other than that, okay. Suppose you are having the problem with grade toe, you can also do these methods to find out the fanning of the other toes. Okay. Suppose the part is amputated or disarticulated distal part, lateral reflex can be used, or you can also go for the straight away tensor fascial end. So basic principles to be applied here is expose the part. Try to look for and try to palpate for the local part to be examined. It's very, very important. Even though repeatedly telling you, it's very important to register in your brain. It has to be practiced. Okay? Yes. Regarding this motor and one more, this superficial reflex of the upper part. Now you will do the demonstration of upper part, the abdomen reflex. What are the basic principles? Abdomen reflex should not be demonstrated in the sitting posture. Never. You can try to do it now, but never do that in the sitting posture. Ideal was only lying posture. What is the requirement? Yes, you know that.
The patient should lie in supine position, and our strike should be from the lateral to medial side.
Basic principle is always expose the part. The strike has to be from outer to inner. Never from inner to out. Always start from outer to inner. You can say 3 quadrants from the postgraduate point of view. Undergraduate, if you are saying 2 quadrants, also acceptable. That is upper and lower. Upper and lower. If you are going to stay it in the middle also, that's really essential for the postgraduate level. But at this undergraduate level, we are going to say 4 quadrants is enough. For them, 6 quadrants. Okay? So 4 quadrants compulsory, you should do that above downwards. Or you can do the outer to inner. The point we remember is outer to inner. What is the expected response? Movement of the umbilicus towards the stimulation site. Movement of the umbilicus towards the stimulation site. One more point you are supposed to look for is quadrant. Anything else? When you are doing this superficial reflex, always take in, if you are feeling like you are dealing with a paraplegia, always do a beaver sign. Always try to do the beaver sign. What is Cornet's test? Go and find out what is Cornet's test. It is basically done from the surgical point of view. Go and refer Bailey Love. Pardon? Yes? அவங்களுக்கு அசிஸ்டன்ட் எழுதி நீயே சொல்லாம அப்படியா யோசிச்சு ஸ்விட்ச் எனக்கு தெரியும் சொன்னே சொல்லாம yes correct leg raising head raising Cornet's test is what is it for what's Cornet's sign so all these things are homework. Go and find what is Cornet's test and what is Cornet's sign. Okay. So this is regarding the abdominal reflex which confined to the motor system. And moving on to the upper part. Morning is to be discussed about corneal reflex and conjunctival reflex. The upper part, corneal reflex, very important. Look straight, wisp of cotton, only touching the upper cornea at the junction. Don't enter into the field of cornea. Don't touch the sclera. Okay, it's very important at the junction. Limbus part to be touched, wisp of cotton, patient eyes to be fixed, distal, and bring the object like this. Okay, clearly explain to the patient. That's very important. It's all discomfort to the patient. Clearly explain to the patient. This is regarding this part. Then conjunctival also similar way, but doesn't carry much of meaning than your corneal reflex. That carries much important. Already morning itself we discussed about how to perform the pharyngeal reflex. Morning itself we already discussed about the jaw concept. I think we have completed all the reflexes part is concerned. Supervision and the deep reflexes. Important points to get. Frequently asked question from the exam point of view is going to be plantar response. Okay? We'll sensory part examination. We'll come to the cerebellum and yeah.
So one is some of the examiners, teachers also. So they will triceps reflex. They will hold like this, and or just simply they will hold like this and do it without supporting over the chest.
The examiners and the support in the patient's arms. Whether you're holding it like this.
No, whether you can hold away from the chest also.
It's very important. This part especially. Suppose you're going to hold it like this, it is not stretched.
Yes, sir.
You're going to hold it like this, stretched. But I don't want this muscle tendon should not be stretched too tight or too loose. So whatever the position, whatever the examiner's role in the holding the position doesn't matter. It's very important stretching of the muscle. The basic principle is to be updated here is stretching of the tendon is strong. You can't keep a finger here. So you just try to hold it in such a way that it's stretched.
So you can keep it over the chest. Just keep it.
Yes. But it will be different from the example sitting posture. Doing the lying posture, yes, possible. But sitting posture, very different.
Another point is that lateral to medial is okay, sir.
Yeah.
So when we were in the demand room, in the upper segments, sir, so they are doing better because of the stretch of the abdominal muscle. It is better to do like this towards the umbilicus instead of doing like this. It is
So we are
towards
going to do from here like this.
Ah, yes, sir.
Yeah, correct.
No, sir. Actually, in the books it is given lateral to medial, it's not towards umbilicus. But the correct way is, in their discussion, they are telling that from lateral to medial, okay, sir, but lateral to umbilicus. The other one is like this, sir, like this.
No, the umbilical point is center point. For upper quadrant, do it from here to this point.
Ah, that is the better way, sir.
And
Because
here
of-
also same. It is not like going above or below upwards. It is only direction of, for example, right iliac fossa towards the umbilicus. Left iliac fossa.
Lower segment also, sir.
Lower segment. Towards the umbilicus.
Both upper and lower.
Both upper and lower going from below upwards or away from outer cranial
Outer chain.
towards the umbilicus portion.
So what we have taught there,
No,
sir.
it is not like a straight line like this. We are not going to go for straight line. It is only straight line.
Towards the umbilicus. Upper segment, sir. Lower segment, there is a doubt whether towards the umbilicus or
Yes.
towards the symphysis pubis. Because of this abdominal muscle arrangement.
Here that we always do it like this, we always do it like this. Diamond shape. But diamond shape, that's what Sar is talking about, from above downwards towards the umbilicus for the upper part. And it is towards the pubic symphysis. And that's what Sar is also talking about.
So only thing is that I know the for a quadrant. So we had a discussion to make this because uniform.
Yeah.
So that day we have called in neurologist also. Very long discussion. So there, the upper segment they are telling that previously we were doing like this. Right? So in the upper segment, above the umbilicus they are telling doing towards the lower segment of the
From here, like
That's what. Okay, sir.
I don't know.
Yeah, no issues.
And the other ones are most of
teachers, they will do like this. It's like holding like this, and they will also do it.
No, basically it's requirement in this teaching. Not requirement.
you got to clear the doubts.
The student at the reflex class, yes. If you're able to do it also, it is very important.
You can ask because
For so lying posture is easy for you to do that. Even lying posture is easy for you to keep crossed and demonstrate the triceps reflex action. Sitting posture, our idea is to stretch the tendon. This is basic physiological steps required for demonstrating stretch reflex. Which is the ideal question is going to be, you don't sit like this, you don't sit like this, just keep it like this also for the stretch. I don't want to stretch, I don't want to keep it too loose. That's all only point.
supinate. You can ask.
Crossed. No, whatever is studying is not acceptable. Only point is basic principle, the position is not the only important point. The basic point should remember is the stretch of the shoulder. She was also trying to demonstrate discipline reflex, it was not so brisk. But when to do that in a different way, I was able to demonstrate. Same muscle, but expression of the function is different. Because the optimal position is offered to the muscle to express this function. That's the basic point. It's not
Patient can't able to cross the legs means what we can do?
for what?
For knee just.
You're not doing that this way. You're not demonstrating this in any posture. Make the patient lie down to do the demonstration. So all these things are applicable for the patient who is having a normal movement of the joints and things. Okay? Yes. Biceps no. Biceps no. Biceps no. The lying person can do that, or the chest roll also can do that. All right. But not for the biceps. I'm going to keep cross for the biceps. That's what I've been telling you. Physiologically, the optimum position, the optimal environment has to be offered to the muscle to express its function of the receptors to stimulate. What receptors? What receptors?
Golgi muscles.
Golgi tendon apparatus is going to be stimulated for your more physiologically to that, but it's very important. Golgi apparatus, tendon apparatus. And we will discuss about the corneal, conjunctival, pharyngeal reflex, jaw jerk is over, abdomen reflex, plantar response, the different methods to look for. Next is the sensory part. Before that, we want us to move on to the coordination, cerebellum part. We'll move on to that, followed by sensory part. Who is going to demonstrate? Different people. Okay, part 1 is over, part 2. Yes. Before that, any other expression findings can you find out in the sitting posture? Frontal ataxia and titubation. So both we look for. That means you are trying to fix the disease at vermis. Okay, you are trying to fix the disease at the vermis level. So try to look for the neck position or the head position followed by the truncal position, sitting posture, which you cannot demonstrate in the lying down. So start with inspection, trunk and the neck position, followed by eyeball. So eyeball are supposed to look for nystagmus. Okay, what type of nystagmus? Gaze evoked. Depends on the severity, but it doesn't matter what type of universal nystagmus. It can be jerky, horizontal, rotatory also. But most of the time, the rotatory nystagmus is happening with go ahead. Then next, nystagmus. Then how do you look for nystagmus? Show me that. How to look for nystagmus? How to look for nystagmus? Very basic, essential requirement for demonstrating nystagmus. Fix the head. Okay. Follow your fingers or object, then something done. Yes? You should not try to demonstrate nystagmus in the extreme positions. Very, very important. Never try to do that because of fatiguability. You will be getting nystagmus. That is called as fatigue nystagmus. Slight oscillation will happen. When you are going to try to keep the object like this, you will be getting the nystagmus. That is 110, 120 degrees angulation. Even 90 degrees beyond that, you will be able to see the nystagmus. It's called as nystagmoid movement. It is not nystagmus. So try to avoid to look for nystagmus in a true organic disease patient of cerebellum, vestibular or ocular reasons for nystagmus doesn't matter. Never try to look for an extreme positions. Always try to look 60, 70, 80 degrees, not beyond that or from the center point. Never try to do that. Okay? It's very, very important basic point you remember. So you're able to identify the slow component and the fast component. Which is abnormal? Which is abnormal. Slow component is abnormal. Try to correct by the body system by the fast component. Okay? Towards the side, whether it's a vestibular, cerebellar, is next level of learning. You are doing this only a clinical examination. Go and read about that part later. Okay? Yes, but basic point when you try to look for the nystagmus, try to avoid extreme position. Okay? Then, I will show how to look for nystagmus. Next step. Speech, yes.
Scanning or staccatos.
What are the common words you use or terms which you should try to look for to look? At least let the word to be used for demonstrating whatever you like. You can use whatever the name you want to say. Let the name has to be or let the term has to be used for demonstrating the scanning or staccato type of different types of problems you are going to see with your cerebellar disease. Okay, not with what is your name? My name is Kupusami. You will not be able to say this patient is having a staccato speech or scanning speech. It has to lengthy one. Okay? Simply repeating the answer. Whatever question you want to create, you can create on your own also. Then, after the speech,
Tone, hypotonia.
I already discussed about how to look for the tone. So remember the prerequisites, tone examination, it's a passive examination. Agonistic group of muscles assessed for the tone and always expose the muscle, always try to palpate the muscle or demonstrate the power and the tone. These points to be remembered. Okay, go ahead then.
So then we should check for a posture. In that we can see tongal attacks here.
What will we say? Coordination, yes, tell me the tone.
Tongal nose.
How to check for it?
From
3.
தூரத்திலிருந்து ஒரு கை எடுத்துட்டு
Why don't you demonstrate and show it? Come to the front of the patient. Come to the front of the patient. You show you what you are going to do and ask him to follow your instructions. ஒரு விரல். Repeated movement of your finger to nose, it has to be done in a fast manner. Okay? That is the opposite side also. Make it for you to easy for you to demonstrate the final problem, how do you do? Suppose final way to look for this coordination, dyspepsia. Finger nose. How you will demonstrate finger nose? It's easy to touch your hand. You want to do? Touch the only finger. So what is basic requirement? The object has to be keep on changing its position for the patient to touch the object tip. It's very important. It should not be kept in the static position. It's like similar to your finger nose test. Basic idea is to make the picture more complex for the system to express and execute the function. In that case of problem of coordination defect, you will not be able to reach the target. Okay, keep on changing the target is the basic principle to be applied for finger nose test. It is not static position. That's a basic requirement for finger nose. The next, rebound phenomenon. Two important requisites.
Protect the
Protect the patient and try to offer. He is always very angry with us. Thus he is trying to express that he wants to go against us. Okay. Then, yes. Always try to offer resistance. Yes. Then, next is wait this. It's not this diadochokinesia. This is only for abnormal movement. Movement test is called as diadochokinesia. Okay? It's going to be abnormal. You're going to say this diadochokinesia. What's the name? Diadochokinesia. Yes. Test is diadochokinesia. So here. Instruction has to be clear. Okay? Yes. He should not hurt himself. Right? It's very important. It's understood. Usually the important is how to check for it. Anything else is missing out? Okay, then knee joint. Show me the heel knee test and joint deep interflex. What is required to say pendular knee jerk? It is not oscillation, it's equidistant oscillation. That's very important. The movement should happen equidistant. It is not just a movement alone. Equidistant oscillation of more than 3 is going to be your classical sign of pendular knee jerk of cerebellar disease. Whereas clonus, more than 4 contractions, at least 4 to 5 is acceptable as a clonus. Repetitive contraction of the joints to be happening to say it's a clonus. It's an extreme form of your hypertonia, right? Hypertonic patient, you have the clonus. Okay. Yes, heel knee test, what's the prerequisite? So always try to go in the lying position, ideal position. Then always ask the patient to lift up the hip joint or leg. Then bend, put his heel on the knee joint over the patella. Then drag on down to the level of knee joint, the ankle joint. Okay, above downwards. It is not like keeping it like this. He has to lift up, bend, then drag on from the patella to ankle joint. That's how you are supposed to do, demonstrating the heel knee test. It's how it should be performed. Okay? Yes. I think everything is done. Yeah, toe finger also another test. You can do that. Slide down posture. The examiner finger is placed 1 feet, at least 1 or 2 feet above that. It should be at the distance of reachability by the patient. You cannot keep it as hospital touch is not possible. See to that it's not practically possible and more practically applicable also. Reachable site, then ask the patient to touch your finger by his toe finger or toe. Okay? And try to change the position also acceptable. Okay, to find it more easy for you to. One more important test for posterior column. Romberg's test. Romberg's test, underline Romberg's test is for posterior column sensory ataxia, not for cerebellum. Repeatedly, because all the books mentions examination dates always mention the cerebellum. I don't know where is the problem. So always the demonstrating the posterior column with Romberg's test is very, very important. How are you going to do that? Yeah.
And hands close to the body. Then we should in cerebellar problem.
No. How to demonstrate? First, eyes open, ask the patient to stand. Able to stand erect without much of wobbling to be assessed. Then eyes closed and is able to maintain the same posture or not to be assessed. Small wobbling can happen, doesn't mean that you are dealing with the posterior column. If you are going to stand, assuming you are not having any posterior column, you will be having mild wobbliness. That is not a sign of posterior column involvement. It's very important. Close as much as possible by the patient, and it has to be maintained with the eyes opening and eyes closure. Eyes closure alone is having the unsteadiness. It's a sign of posterior column. Posterior column. Okay. Yes. Visual input is lost. You'll be getting that. Okay. Because cerebellum, even eyes open, you will not be able to perform or stand upright with this posture. Tandem walking. How to do that?
We should ask the patient to look straight.
So very important prerequisite, straight looking, not looking at the floor. Number 1. Number 2. It has to be kept with 1 foot in front of the other feet. Ideally touching the other feet. Suppose not possible because of practical reasons, 70-year-old man, you are not able to ask him to perform that, at least acceptable to slightly in front of the previous feet. Acceptable. But see to that the patient should maintain the straight line walking. Mild swaying is acceptable. Very important. All practical difficulties or fallacies of the test. So you should accept that. But gross deviation is going to be not acceptable. But you should not fix the eye on the floor. You should be looking straight, not on the floor. Very important. Okay? So basic prerequisites. Anything else we have missed out? Gait before that sensory part. Because you've done your cerebellar part, coordination part, motor part almost finished, and you're going to the sensory part. Which sensory experts? Oh, what are the basic prerequisites for sensory examination?
First, you should ask whether he could feel anything. First, you should ask the patient whether he can feel anything. So, what is any sensation? This is for normal cycles. Whether he is having sensation.
So, any sensory examination, for that matter, any neurology examination always start with the normal side to the abnormal side. Assuming it's a unilateral disease. Assuming it's a unilateral disease, always start with the normal side or abnormal side. But what's the prerequisites for sensory examination? There are two ways to examine the sensory system. One is, as far as the spinal disease is concerned, you can go for the dermatomal distribution of sensory examination. Morning we discussed about C1, C2, C3. So dermatomal distribution of sensory examination, one of the ways to look for. Similar to the examination trigeminal nerve. What we discussed, you can go for V1, V2, V3. Keeping in mind the C2 part is there, as a part of small part is there. This is one way. Another way to look for the examination sensory system from the tip to tragus or tragus to the tip. There are two ways to look for. Similar way, sensory examination is also done for the whole body. Two ways. One is dermatomal distribution. It's more applicable, easy for you to perform if you are suspecting a special spinal cord disease, and you can easily localize the disease at the sensory level is concerned. Other one is general principle of sensory examination tells you that always start from distal to proximal. Always start for the examination distal to proximal. Always starts from this afferent pathway. All the sensory inputs are given as an afferent pathway. Always start to distal to proximal. It's more applicable for posterior column, more applicable for spinothalamic tract also. I'm talking about only the lateral spinothalamic tract. Okay? Yes. Yes. How are you going to demonstrate?
So first, dorsal column, fine touch, joints and circumferential.
Tell me the joint and proprioception. So this rule has to be applied, principle has to be applied. First one is from distal to proximal. Okay? Yes. You can ask the patient to verbalize the same, or you can ask the patient to show on the other side. Show on the other side. If you are saying that you are going to move up, ask him to show in the whichever direction he feels you are going to move. You are going to move, ask him to show on the other So what is wrong with her? Anybody? Always hold the distal most point. Number one. Don't hold the whole finger. All these things are receptors. I'm just going forward like this. And she is trying to do the joint movement. How much is the movement is allowed? Only few degree angle is allowed, maybe at the maximum 5 degrees or 10 degrees allowed, not more than that. It cannot keep on moving, dancing movement, up and down dangling movement cannot be done over there to demonstrate is there any intactness of the joint position is there or not. Okay, even this sensitive area like this, even 1 millimeter, 2 millimeter movement can be appreciated by the joints. That's all the sensitivity of the areas. So if you are not able to appreciate that from the patient's point of view, disease point of view, it's abnormal. Okay? Age is concerned, definitely you expect the sensation to go down. At the age of 50, 60, 70, it goes down. Okay? So naturally the age, naturally going to have some sort of disturbance of the joint position sensations, vibration also. It's going to be all in the decay status. It's very important is holding this part, not anywhere else. Number 2, it should be done like this, not holding like this. And movement is only happening 5 to 10 degrees, not more than that. Ask the patient to have a look before doing the stimulation or testing. Ask him to understand what you are trying to do and ask him to perform the same movement on the opposite side. Easiest way to do that. And by chance, you might be right 1 or 2 times, we are going to do 5-6 times. Out of maximum times, it is not able to perform, it is understood absent. Sometimes it happens that you will be able to perform correctly what the direction you are trying to push the finger, but not necessarily. Both the boys come here. Come. Very amusing things are coming. Come. Come. Fast. Very practical. மாத்தி படிக்காம இருக்கு. படிக்காம தம்பி. Where is tuning fork? Here. Demonstrate. Show me that. அடிக்க போறீங்களா? கண்ணா மூடிக்க சொல்றீங்க. என்ன பண்ண போறோம் முதல்ல சொல்லுங்க. என்ன உணர்ச்சி வரும் டாக்டர்? அவர் புரியுற மாதிரி சொல்லுங்க. அது எப்படி காமிக்கணும் நீங்க? காமிக்க போ. அது எப்படி இருக்கு எனக்கு தெரியாது. அது எப்படி இருக்கு எனக்கு தெரியாது. எங்க வைப்பீங்க? எவ்வளவு தப்பு பண்ணீங்க பாத்தீங்களா? கிளாஸ் எடுக்கும் போது அமைதியா உட்கார்ந்து கவனிக்க முடியல. டிஸ்டர்ப் பண்ணக்கூடாது. Don't disturb the environment. You come here, Thambi. Fine. You show me how you're going to demonstrate pain and temperature sensation. எது கண்ண மூட சொல்றீங்க? என்ன பார்த்தாங்க? நான் அதோட பார்த்துட்டே இருந்தேன். நீ வா சிரிச்சுட்டே இருக்கிறீங்க, உட்காந்து பேசிட்டே இருக்கிறீங்க. The same you are going to perform the examination. If you are not able to demonstrate your clinical sense here, you will not be able to demonstrate the examination. When there is a helping from your department, from your institution to help you people, try to utilize that help. Don't think you know everything. I don't know anything. That's a test for me. What about you? Never disturb the environment. Clear? You should feel ashamed of yourself. Disturbing the class environment, you should feel ashamed of yourself. If you don't feel, it's once again a shame on you. If you are not able, at the final year level, if you are not able to perform and show your skill of demonstrating your joint position sensation and vibration sensation, what learning you have done till this time? Nothing. Should have been learned by the time of second year. When you enter the clinical posting, first year clinical posting, already physiology is being taught. It's not a new subject we are trying to learn here. We're trying to make ourselves familiarized to make it very easy for you to perform in the examination. It is not first time we are teaching you. It is not only teaching you of your clinical skills, but also making you to understand how to apply your basic science to clinical practice. It's application of your physiology, anatomy, your pharmacology, microbiology, whatever, into the medical practice. It's application session. More attentive. Okay? One more boy is also waiting. Catching is going to make amusing things. We'll go back, both are. Show me how you're going to sorry about this. Go about with this joint position sensation, vibration. Which tuning fork already discussed about this? Only 128, not more than that. Don't forget 128 for joint position sensation. Okay? It's a vibration sensation. Not for 256, 512, 1024. Okay? Nothing is to be used. Never make a mistake. Yes, because of the reason I told you morning, long decay time. Long decay or slow decay time is the basic reason for, so that you get it transmission time. Because time required for the transmission to happen to the level of spinal cord. Okay? So 10 seconds required for this upper limb part, lower limb 20 seconds is required. So when you are going to have a tuning fork, vibrating one, which is going to take its time more than 20 seconds for the decay, that is good enough to stimulate the joint or they stimulate the receptors at the joint level. That's the basic idea about showing this vibratory sensation with only 128 tuning fork. Yes.
Vibrations is tested in more prominence, like median malleolate, Reagan's tidal process.
Always start with the distal most point. Never forget the once again the basic dictum of examination. Starting from great toe. Great toe is the first point. Joint position sensation, DIP, in the upper limb. The great toe part. Vibrating sensation, great toe or the DIP part. Then go medially till you get the level of sensation. Once you start appreciating, stop doing that. No need for proximal. The proximal joint vibration, position sensation lost in case of which disease? Caries dorsalis, tertiary syphilis. Otherwise you don't get. Otherwise you can also get syringomyelia and syringobulgia, you can get loss of sensations. But it's very important, sensation the proximal part. Otherwise usually you get in the distal most point. Once you start appreciating, don't go beyond. That means don't waste your time looking for the all the joints for vibration position sensation. Okay? Yes. Here you go. Easier. Yeah. So always try to choose a very prominent bony portion here. You can also start from this point. Always start from this point. You can also do it from here. This thumb region also. Do it from the great toe also. There's a basic point you should remember. Always do it from the distal to proximal. Never try to go for proximal side. Okay? Yes. Only the touching of the joint has to be done by the tuning fork, not with your fingers. It should not impede the vibration sensation. The sensation carried by the joints should not be disturbed by your finger position. You can ask him to show it the other side. No. Keeping it here, ask him to show. Otherwise, you can say that he is able to appreciate or not. Most of the time, the wrong interpretation by the patient is only the touching is appreciated by the patient. It's only the vibration has to be appreciated. So make sure that the patient is appreciating vibrations, not the touching sensation. We'll move on to the next part. Vibration positions, touch and temperature. So pain and temperature. Pain and temperature. Take care of it.
Supervision pain or first you can instruct the patient what you're going to do and then ask
Yeah,
them to do
always go with the dermatomal distribution. Always easy and more useful from the exam point of view, from the practical point of view, go for the dermatomal distribution of checking for. For which you should know the dermatomal distribution picture which is given in your Atchison, not Atchison. Atchison's clinical methods. Atchison is not the written book, it's not the name behind it. The written book is on Atchison. Okay, Hutchinson is different, Atchison is different. So Hutchinson's clinical methods clearly gives you a picture on the dermatomal distribution of the sensory examination. Ideal one, more useful one. Okay, starting from our neck portion C2, C3, C4, C5, and we told C6 follows. Thumb is concerned 8, 7, 6. This is 8, 7, 6. Then T1 is there, T2 is there. Then go to just one. Okay, and T4 level, T6 to T12. Then we have the L1, L2, L3. This we should know the distribution of this. Not the class is not meant for that, but always going to go for the dermatomal distribution of the sensory examination. So how are you going to do that? Try to avoid deep pain sensation. Exam point of view, practical point of view doesn't give you much of information. Better to go for special pain sensation. Better to avoid. It's more painful. Sometimes you don't get cooperation with the patient after that. That also you have to keep in mind. Okay? So all these leniencies are accepted from the examiner's point of view. That is acceptable. So they will not find fault with you at all. Okay? Yes. Another principle is any sensation of this nature, especially pain, temperature and your touch sensation, normal side followed by abnormal side followed by one more. Sensory is concerned, one more time he has to do that. The other principle I told you, expose the part, inspection, palpation, and looking for all those stuff. Sensation is distal to proximal, dermatomal distribution, all those principles you should keep in mind. After demonstrating unilateral, one area followed by always try to demonstrate both the sides together. Both the sides together. That's very important. So you'll be getting the non-dominant parietal lobe lesions, sensory extinction or it is called as sensory inattention. Be able to get as a problem where individually looking for the sensations, patient will be able to appreciate, but together the patient will not be able to appreciate the diseased side. It's very important. Individually, right side checking normal, left side checking normal. Together, if the person is having a problem of the sensations on the right side, you will say you have kept only on the left side, not on the right side. So that means it's called as extinction of sensory problem, or otherwise called as sensory inattention. Okay, it's very common problem of the parietal lobe involvement. So it's very important. One additional point which we have to remember about, other than the doing in the normal side to the abnormal side, unilateral side, dermatomal distribution, distal to proximal, followed by do the examination of the touch and the pain and temperature together on the both sides simultaneously. It's important principle. Try to know that, try to practice that. Okay, that's very important for the examination. Sensory system is concerned, both pain, temperature, touch. Touch how are you going to perform? Show me that.
There is two touch, fine touch and crude touch. For fine touch, you can use a whisk of a cotton, make it into a ball, and touch the different dermatomes.
Show me that. Both crude and touch, both fine and crude. So touch sensation is concerned, never try to draw a picture on the patient's body surface. Never try to draw a picture on the surface. What are you supposed to do? Touch and find out. Just trying to do S, C, D, some sort of letters, alphabet she is trying to draw. That's not expected for demonstration of the touch. You must touch and find out the knot. Okay? Then crude touch, crude pain, even Achilles tendon pinching. So all those stuff is there, but at the undergraduate level I'm expecting just, if you know the techniques, basic principles, that's well and good. You are qualified to get to the next level of learning. Okay? Which is not really required to have a complete detailed examination. That is, these techniques and principles we are very clear, expressing to the examiner, you are in a smooth sailing of the examination is concerned. Okay? So you should know about the touch sensation is concerned. Anything else you have missed out? Cortical sensation. Yes, go ahead. Thank you.
Cortical sensation, two-point discrimination, tactile localization, anesthesia, and
Other time somebody was asking about two-point discrimination. Now I was you are only asking. Don't, yeah, go ahead.
first tactile localization. Done with the object like the pen is touching on one, and the patient localize the same.
The site of touching has to be pointed out by the patient on the other side. That's a basic tactile localization. Where the examiner is touching has to be pointed out by the patient on the other side, opposite side. That's a basic idea of tactile localization. All these reflexes called as latent reflexes. Whereas primitive reflexes are Jean-Jacques is not primitive reflex. Clubber tap, snout, palmomental reflex, rooting reflex, yes, snout reflex, all these things are primitive reflexes, released reflexes, always called as released reflexes. Okay. Always known as sign of diffuse cerebral involvement. Diffuse cerebral involvement. Generally you can say that way. Okay, there are specific areas, but if you know this point, I think good enough for the undergraduate. Yes. Go ahead with the other point. Tactile localization other than that. Yes, go ahead. Even narrower than that. It is not 5 millimeter. Narrower than that. When 1 to 2 millimeters, multiple receptors, I was telling you, small distance is enough to appreciate the 2 points. Whereas the chest wall at the back, at least 4 centimeter. You need to appreciate that your examiner is keeping 2 points, at least 4 centimeters should be there. 4 centimeters should be there to say that you are dealing with it. 2 points are applied. So the receptor placement is bit of wide, so you get a wider distance to say that you are dealing with 2 points. So 3 to 4 centimeter on the back. The finest point is, even finer point is little lip. Lip is the very finer point, multiple flooded with or studded with receptors. So this small point, 1 millimeter distance is enough. Maybe 2-3 millimeters over the fingertip goes slightly wider distance for the proximal points. Okay, because of the receptor placement. Okay, yes. Then 2-point discrimination, tactile localization, stereognosis.
Object like keys or watch, if the patient is familiar with the object, it should be kept in the palm, and by closing the eyes, the patient should find which object was able to feel the object.
So the placement of the object in the hands, ask the patient to close his eyes and ask the patient to identify the object. We should be more familiar with the patient. That's very important. The next one. Graphesthesia. Tell me that. What is that?
The patient eyes should be closed, and in the palm, we should write as 1, 2 numbers or alphabets. The patient should be able to.
Very simple linear lines should be avoided. Okay? The basic principle is you cannot write 1, 11, 1, 1, 1, 1, 1, 1, 1, 1, 1. That's not expected. Okay? Some sort of curvy lines or letters, alphabets, some sort of Tamil letters, Malayalam letters, whatever want to write. All these curvy ones should be there to make the patient to appreciate what their examiner is trying to project on the arm or the chest wall. Okay, yes. This is only basic. The cortical sensations is carried through your posterior column. It's all carried through your posterior column. It's very important. All these things are carried through your posterior column. Anything else you missed out? We discussed about motor part, sensory part, irritation sign, cerebellar part is over. Yes, how are you going to demonstrate meningeal irritation? How are you going to demonstrate? Chronics. The basic requirement of neck rigidity is concerned. The patient is lying posture, definitely, because you are suspecting meningoencephalitis and meningitis. The head should not be upright. It's very important. There should be a pillow below the patient's neck also. Should be straight, flat into the surface of the bed. Then you try to lift up the neck portion, make the patient's head to touch the chin to touch the chest wall. That's the basic idea. Try to do that. How much resistance you are offered by the patient or you are experiencing, you will decide upon are you really dealing with neck rigidity or not. Okay. Before that, age of the patient, the neck bone, cervical bone stability, all those things to be looked into. Patient is having severe spondylitic disease, rheumatoid arthritis. After movement of this, will make the patient become quadriplegia. Okay? See to that all these prerequisites are very important. At your level of learning, you try to grasp all the prerequisites. Principles of application of clinical medicine is very important. Application of this knowledge into next level is going to be postgraduates. But without knowing this, without registering these points in your brain, it's very difficult to practice. Medicine is a voluminous subject. Sounds very difficult, but one of the easiest subject to learn. Medicine is one of the easiest subject to learn. I always tell my students because it's a mixture of all the subjects. Whatever you learn, if you take anatomy is there in the medicine, physiology is there, biochemistry is there, pharmacology is there, microbiology is there, SPM is there, forensic medicine we discussed about certain parts. ENT ophthalmology is there, everything is there. Only thing is for 20% you have to study extra. If you are good enough in your basement, it's like a very joke. If basement is not good, very difficult to learn medicine. So basement has to be strong. The basement is very easy. Already you learned 3.5 years. It's very easy to learn medicine. Everybody finds medicine as a subject is very toughest subject. I wish it's the easiest subject to learn. Recall your basic science, add only 2 points, 3 points to your basic science reconnection. Done. Through. Exam is cakewalk. Just easily go through the exam and you just pass. Applicable to postgraduates also. They're just looking at me, but it's applicable to postgraduates also. Applicable to everybody. It's one of the easiest subject to pass. Okay? Yes, next time basic requirement is this one, followed by
Curling sign. First ask the patient to lie and then flex the knee to 90 degree and hip flexion also. And you ask for any pain and stiffness in the hamstring muscles.
you are supposed to feel for it. It's not only ask the patient, always try to feel for it. You know the difficulty of lifting up from the 90 degrees. Yeah, you will not find it. That's a sign that patients, because patients might be in a comatose status. Meningoencephalitis might be a disoriented position. You will not be able to answer your question. Okay? Yes. Brzezinski sign. Brzezinski sign. Yes.
So you ask the patient to flex the neck. They do also flexion of both the legs.
Lower lip.
Lower legs.
Yeah. It's very important at the UG level, at your next level of your learning would be internship. If you are a bit of clear about how to look for this Koenig sign, neck stiffness and Brzezinski sign, that's well enough, which you are supposed to practice at the emergency department level. When you are going to post to the casualty, when your senior is saying, I'm suspecting this patient meningoencephalitis, the postgrad is telling you, please tell me how to look for this patient, Brzezinski sign, how do you look for this Koenig sign, how do you look for neck stiffness. Let me try in this patient, it's going to be next level of learning. You're supposed to practice. So try to utilize this type of clinical materials, try to practice at the patient level. But at the same time, considerate for the patients being a human being. You are also a human being, but it's very important that at the mercy of the patient, you are trying to learn. Unless you says okay to you, you cannot learn. How much bowing or down to earth you have to be there with the patient's level to learn your medicine is very important. You are boss, no, you are not boss. You are only at the receiving end. He is at the giving end. So always see to that the patient is very important. Clinical medicine is concerned, the star of attraction is going to be him. He is the star superstar. He is the star for you all. Very important. No, it's not joke, it's a fact. The people nowadays, the current generation is forgetting about that. Joking inside the class, it's not correct. All relaxation is okay. But learning medicine is always a primary target for you. It's very important. Okay? So relaxation, your casualness, all can be outside your classroom. Inside the class, you are all professionals. You are not learning arts. But you are learning your science with artistic talent. This is what clinical medicine is about. The science learning with art. It's a science, it's an art of this clinical medicine. It's not like reading a book. Yes, I read completely 120 pages of Hutchins and I know everything first page, second page. Like that fellow standing here. What I'm supposed to do, I don't know. How to convey the message, how to express the point to the patient, I don't know. So all those things will happen. It is basically bedside. You have to sleep, wake, die, food, whatever happening at the bedside. You will learn medicine. Otherwise, you will not learn clinical medicine. It has to be at the bedside. Each and every patient will give you some clue for the clinical medicine itself. Your investigations, management plan, all based on your clinical acumen, clinical assessment, without which you are going to ask for investigations, without which you are going to ask for medications. You are a clerk. You are not professional. Clerk can do that. All the list is there, tick, medicines tick, whatever you want to give it. It's clerical work. You are a clerk. You are a professional. Always try to maintain your dignity of professionalism by your showing your knowledge. It is not the knowledge alone, skill of managing the patient. It's an art of skillfulness of managing the patient is very, very important. For which, once again, whatever the growth is happening in the investigation part is concerned, nobody can take over clinical medicine. Without clinical medicine, nobody can survive in this world. AA cannot survive. Challenge you. AA cannot survive. Without a clinical medicine, you should all understand that AA is created by human brain, not by anybody else. It's not created by machine. It's created by human brain. So human brain has got that much capacity. Why don't you utilize it and try to apply in the patient? Why do you depend on the machine? Machine is going to be helpful when you are not able to perform on your own. Only for assistance. It's like your books. Books are there to assist you. Patient is there to teach you. Books are there to assist you. Patient is there to teach you. So live patient is there to teach you. Why don't you go and get the knowledge from the patient? So try to spend your maximum time at the bedside. You learn clinical medicine. No doubt about it. I think with this we'll conclude here. Anything else to discuss? I think we've completed everything. Have you, sir? Finished?